Welcome to Key into Quality, the Mayo Clinic podcast, where we explore the people, practices, and principles that elevate healthcare quality and safety. And a special shout out to our Mayo Clinic Care Network members. I'm Dr. Tim Morgenthaler, a professor of medicine here at Mayo Clinic and vice chair of Mayo Clinic Quality. Today, we're focusing on a crucial topic. Your approach is everything, speaking up effectively for patient safety. And I'm really thrilled to be co hosting today's episode with my partner, Sherry Nemec. Sherry?
Welcome, everyone. I'm Sherry Nemec, Consultation Relationship Manager for Quality at Mayo. Creating a culture where people feel safe to speak up, whether we're talking about staff safety or patient safety, it continues to be a focus and an opportunity for improvement for most healthcare organizations.
Yeah, this concept of psychological safety, I mean, it's important in healthcare. It's really a practical way to foster an environment where everyone feels empowered to speak up, but it's not easy to achieve all the time. From understanding what psychological safety really means to addressing the challenges and sharing real world examples, our guests today are going to really provide, I think, some good insights and actionable strategies. So stay tuned now as we learn how to flatten hierarchies, encourage transparency, support employees in creating a safe and open workspace. Let's get started. Our three guests today are patient safety experts from Mayo Clinic, Dr. Abigail La Nou, Jami Zwiefelhofer, and Katie McFadyen. And I'd just like to ask each one of them maybe to tell us a little bit about themselves. Dr. La Nou, tell us a little bit about yourself. How did you come into this role and where are you working now? And enlighten us.
Well, thank you for having us all on, Dr. Morgenthaler. I'm Abby La Nou. I am one of the emergency medicine and critical care physicians in Northwest Wisconsin. I primarily practice in Eau Claire. I started as patient safety officer in 2022, taking over for Dr. Young and having some very big shoes to fill. I had gotten interested in quality assurance and patient safety through my work with the mortality committee. So started out just doing case reviews and then took over as our mortality officer in 2015. So I've really enjoyed working with both Jami and Katie as our patient safety specialists, and Katie was our admin support person for the patient safety group in Northwest Wisconsin.
Fantastic. Thank you. Jami, tell us a little bit about yourself.
Well, thanks. You want to echo Dr. La Nou. Thanks for having us on and being able to talk today. My name is Jami Zwiefelhofer. I work in Northwest Wisconsin primarily, but I do support the state of Wisconsin. I've been in patient safety for about 6 years here, but my roles in healthcare have been diverse over the last 15 to 20 years. So I have had experience within lab medicine, within the hospital setting, within the outpatient setting, and it is so fascinating to be able to see how patient safety needs to be supported in all of those different areas. But the key foundation of all of that is that psychological safety and that bringing patient safety teams together. So
Well,
thanks again. I'm excited to talk.
oh, no, this is going to be great, Jami. Katie, I've known you for a long time, but share a little bit about yourself with the rest of our guests.
Yes, it's great to see you again, Dr. Morgenthaler. We've crossed paths several times over the years. I've been at Mayo for 19 years now, and 16 of those years have been in quality in a myriad of different positions. For many years, I had kind of a broader quality scope. Over the last 5 years, I had the opportunity to work a little bit closer in patient safety and really found a lot of interest and maybe my niche finally in focusing in on patient safety. So now I work as a patient safety analyst for the Mayo Enterprise, just working at that enterprise level on our systems and the different tenets of the patient safety program here at Mayo.
Wow. Well, so we're just excited to have all three of you here. Katie, maybe I could start with you and just ask, what does psychological safety mean to you?
Yeah, absolutely. Sherry kind of hit it on the head right with the introduction today that psychological safety is really a vital component anytime that we're talking about creating a broader culture of safety. Anytime we talk about psychological safety, we have to mention Amy Edmondson's seminal work in this area. She really is our expert that we look to. And she defined it as that feeling that people are comfortable expressing and being themselves, and they can speak up without feeling any type of judgment or blame. What I really appreciate about her work, though, is she says it's not just about being nice, though. It's not always easy. It's not always just being friendly with each other. It's really an environment where colleagues feel comfortable disagreeing with each other. It's okay to ask questions. It's okay to be critical of something that you're seeing, asking for help, admitting mistakes. To me, that's really what a psychologically safe environment feels like. And I think the reason that it's so critical to us in patient safety is we've seen data from the Joint Commission showing that those communication breakdowns are really a leading factor in sentinel events. So we want our environment to be as psychologically safe as possible so people do feel
Mhm.
comfortable speaking up when they see something or admitting mistakes.
Katie, that was a perfect answer. I don't know if I can add much to that, but I totally agree that, when we do see these communication breakdowns, that does account for the majority of the issues that I have seen in patient safety in one way or the other. And I think one of the things that we found in the cases that come up is that when staff feel that they're intimidated or that there's someone else that is not approachable, they really don't feel comfortable speaking up. And that's when we see issues arise with our communication. So I think when we talk about flattening the hierarchy, what we really mean is that the team needs to be able to function cohesively, and no one person should feel intimidated to bring forth any issue that they're uncomfortable with.
What prompted you all to really start looking at psychological safety in your work?
I remember when we were coming up with this topic, we actually first did this presentation for one of our patient safety ground rounds. I think we had had a couple of cases in which we talked about that communication piece, what played a very big role. One was in one of our departments, there was a case where there was a patient that had a procedure and then was developing some instability afterwards, but the team wasn't quite sure what to do with that patient and was a little afraid of approaching the proceduralist. So they basically just did their normal procedure and they moved the patient out of the procedural room. And as it ended up, that patient had pericardial effusion and developing cardiac tamponade after their procedure and ended up decompensating and probably should have stayed in the procedural room and had that dealt with. So that was one case I recall, led to us talking about developing this because I think in that case, the staff were, when questioned, they said, well, why didn't you bring this to the proceduralist's attention or seek them out before you moved the patient? Well, we felt like we would be in trouble or they would be mad at us if we questioned their plan. So we kept the patient as they were. So cases like that really highlight the need for there to be a safe space for the patient care team to speak up and be able to bring their concerns forward.
Yeah, I just want to actually dig into that a little bit with all three of you. This fear of speaking up. Katie, you mentioned that part of psychological safety is not just being nice to one another, but it's actually also being open and feeling safe enough to disagree. Jamie, maybe you want to volunteer me. What are the kinds of behaviors that would cause, let's say, me to not feel psychologically safe? What would be my lived experience that I will have had that would make me not want to speak up? Do you have some thoughts on that? Any of you, but maybe Jamie, start.
Sure, I do. One of the things that I do for our organization is I teach our Department of Nursing as they're coming in as orientees. So I love to ask the question, how many of you will feel comfortable to make that 2 a.m. phone call to the provider when you have your patient who's starting to decompensate? How many of you feel 100% confident? And I don't get many hands that are raised. And then I ask, tell me a little bit about that. What is preventing you? What's that thing that's kind of stepping in your way to say, I don't feel comfortable in this moment to speak up? And I hear past experiences. I've had that experience with the individual that I was calling wasn't very nice to me, or they weren't receptive to what I was saying, or they shut me down in the conversation. Confidence in experience that they've had in making that phone call. I've never done this before. I don't know to expect.
Hmm.
So some of the things that I've talked to them about, and I've asked them to give me some ideas. And so this a lot of this is coming from our employees because they're so important to us and it's so intelligent in this their experiences are so important to us, is one, bring someone along with you. If you're having that first phone call, if you're having that first conversation, bring along that lead, bring along that person that has that experience, and have them be just listening and give you some advice. Number two would be go into that conversation with an approach. So we have SBAR, situation, background, assessment, and recommendation. Have a structured approach to that communication so that when you're speaking to someone and they understand how they're going to receive that information. And then the last thing is just lead by heart. If you're having that conversation and you're leading it with an open approach, I feel like that's the best way to be able to have a tough conversation with someone.
That sounds like some great tips. Before we move on to other thoughts about how to improve the climate for psychological safety, you mentioned I haven't done this before as a reason that so there's a little bit of a lack of confidence in it. You mentioned prior experiences where, gee, I went through this before and I got shut down or they weren't nice to me. Are there other behaviors that we see in healthcare, or probably everybody sees in real life, that make you feel unsafe speaking up? Katie, and I guess I'm going to just say, when you said feeling safe to disagree, I can't help but think of maybe some of the current political environment where if you disagree, we just don't know how that's going to go. But what is it that makes us feel so uncomfortable? Any thoughts on that?
I think we've talked a lot about what people say so far in this conversation, but let's not discount what a nonverbal can tell us too. I mean, if we have a proceduralist or a nursing colleague or somebody who's maybe even aggressively putting an instrument back on a table or showing us a little bit of aggression that's coming out in their
Mm,
actions or their facial expressions, I think we all experience that at work, but we experience that in, the real world. You just mentioned Dr. Morgenthaler. We read people all the time. We're constantly getting all these bits of information and we're processing, and is this person a safe person or not a safe person? So I think about those nonverbals too. So the flip side of that is when we're trying to create a psychologically safe space is being mindful of that. Like, how am I standing? How am I looking at this person? Just being really mindful of those nonverbal cues too.
Dr. La Nou, I want to just go back. You had mentioned about flattening the hierarchy. Can you talk a little bit more about your experiences, how you've worked on doing that?
Yes, definitely. So, medicine in general is very hierarchical, especially on the physician side. I mean, because we have such a hierarchy during training. As medical student, you move up through the ranks as a resident, and then there really is some even still like a hierarchy between the different departments. So it really is kind of built into that culture of medicine. And it can be traditionally very intimidating for somebody lower in the hierarchy to question or, challenge anything that the person at the top of the hierarchy is doing. For example, looking at like your traditional operating room, the surgeon is really like the top and the boss, and then they're maybe their first assist, and then the OR nurses are basically below them. And when we talk about flattening the hierarchy, I have an emergency medicine background. I really do think of the way emergency medicine is structured as being an example of how the hierarchy is flattened, because really you have to work as a team in that environment. It's very chaotic. We rely very heavily on our nurses to notify us. For example, like there are times when we have patients in the waiting room for several hours. So you really rely heavily on the triage nurse to notify you, and that gives them some empowerment to say, I think this patient is not doing well. I'm going to get the physician. And if they're afraid to approach you, like that is not going to work. So, what I've seen in general is just that within our group, we do have a culture where it's expected that the nurses are questioning the physicians, getting them if they feel a patient's not doing well or if they need something. And you also have to do that to maintain the workflow of the emergency department. It's a very busy place, and that goes for many other departments as well. So you have to have a good communication, and do have to feel comfortable with each other to question each other's decisions. So I really think, when we're all functioning as members of a team and we all feel that we have the ability to question each other, that is really my example of flattening the hierarchy.
I think we talked a little bit just about this, Jamie, with you and talking about what you do in orientation for nursing. But are there other things, and this is to anyone who wants to share, around examples of how psychological safety is being implemented in Wisconsin?
So, a couple of things that we do in Northwest Wisconsin is making personal connections. When we go around within the units, it's really important for us to be able to connect to the patients, connect to the employees, and just show support for a culture of safety. When we have conversations, we ask, what's that thing that keeps you up at night? What's that safety concern? What barrier can we take away to make sure that you're able to practice safely? When we have conversations about communication, so a little bit back to that last topic, and we talk to the nursing staff, I ask them, when you have a conflict with another nurse, another provider, and you have a couple of different choices on which way do you want to go, you can confront that person or you can ignore that person. When we do ignore that conversation, when we stop communicating, who are we hurting? And when we're standing in that hospital room, the patient is between us. That's the patient that we're hurting. So that communication, even though it could be a really tough conversation, is an important one to have. So a lot of times we'll talk about how do we communicate with each other? How do you have a disagreement? How do you, like Katie said, how do you disagree with someone in a way that's fruitful? How do you have that conversation? So the building relationships is that being transparent when we have an event come through. We want to be transparent with the patients. We want to be transparent with the staff. We want to be transparent with the organization on how we're going to move forward. How are we going to improve to make sure that that never happens again? And one of the beautiful things that we do at Mayo Clinic is we do not focus on people, we focus on process. How do we improve that process to make it never happen again? How do we improve it so that the next patient that comes in where that situation starts to Swiss cheese us, we stop it right away so that we can have
Mhm.
the safe patient care.
I'm just kind of curious. So you've mentioned a whole bunch of interventions. You've mentioned making sure that we have familiarity so we know the people as people that we're working with. You've mentioned just the importance of inviting things. I know as a physician who's led rounds on the hospital services and even in the outpatient, you can just see a completely different tone if you just take a moment to invite people to say, hey, does anyone have concerns? I really want to hear them. That invitation. You've mentioned rehearsing. So there's a way that you can bring up something that might be more better received and other ways. You've mentioned bring somebody along. Dr. La Nou, maybe you could just talk a little bit. What type of training are physicians receiving to help us with this process? Because you've mentioned that often there's a hierarchy that's part of this, or at least a perceived power differential. It's not always the cause, but it's there. Tell us, what are you seeing done to help physicians become part of the solution?
So that's a great question. I think if we're looking at what I'm seeing with the medical school trainees and resident trainees, it does seem like the culture is changing to where they are encouraged to speak up as residents. I think when I was a resident, traditionally, when you were earlier in training, I think it was discouraged for you to speak up sometimes if you're seeing issues. And I think now the culture fortunately is changing where, when we do our workshops, early on with medical students and residents, in patient safety and in other areas, we make sure that we are highlighting those strategies for communication. When our residents are rotating, we're saying, don't be afraid to approach your attending. Don't be afraid to question things. We're not here to just grill you. We're here to learn. We're here to create a team. So I think that that is the approach I'm starting to see more often rather than this hierarchical approach. I think as far as, physicians that have been out of training do have, our physician communication workshops. We do have, for example, in patient safety orientation, we do go through scenarios with our new physicians. We give examples and we give expectations of what we think the culture at Mayo Clinic should be. We say we really expect you to be a physician leader. We expect you to set an example and be approachable and promote good communication and really foster that culture where people are going to be comfortable approaching you with any concerns.
Fantastic. So, Katie, I'm circling back to you again because you said another thing that really stuck in my mind. You made the differentiation between the verbal aspects of how we let someone know how safe or unsafe we are, but Then you mentioned the physical things. How should I police myself when I'm in a group so that I'm communicating openness and so forth? Do you have thoughts on that?
Yeah, I think the biggest thing when it comes to psychological safety, and I think this is really difficult to do. So I want to acknowledge this that as humans, sometimes our brains work a little too quickly, and it's really easy, especially in a tense situation, to get defensive right away.
Mm.
So I think that's the first thing is, and again, this is difficult, but intentionally practicing not getting defensive. When that person is coming at me with some criticism of something I've done, I first want to assume positive intent. So if I can take a step back, take a deep breath, and slow that brain down and think about, okay, what is this person's motivation? Why are they coming to me with this? Well, they're coming to me with this because they want my patient to be safe. So I'm assuming positive intent. I think that that can really slow the brain down, stop those defensive mechanisms. And then I can turn on that better part of my brain, my active listening brain, and again, really be able to ingest what this person is bringing to me more effectively.
Oh, that's such great advice. So, what would you say, Katie, to someone, let's say an employee that is struggling with psychological safety?
What I would say to someone who's struggling with psychological safety, I think when we encounter staff who share with us those examples of times that they have maybe had a negative encounter, first we want to acknowledge their experience. We want to say, I'm really sorry that happened to you. Thank you for sharing that with me. I think that acknowledgement of what folks have gone through can really go a long way for someone to see, okay, here's a safe person in this organization. Not everybody here is an unsafe person.
Mm.
So I think opening that door is really important. But I would throw it out to my other colleagues who, I think, on a more daily basis, have the opportunity to help staff with this.
Well, if you don't mind, I'm going to give you a personal experience. So early on in my career, I had a conversation with one of the higher ups in a hospital, and it wasn't going well. And this was a phone call, so I didn't get to have some of those physical cues to be able to look towards, but I could hear in the voice that the conversation was starting to escalate. And we were talking about a patient safety concern that had kept coming back, reoccurring. And the individual I was speaking to started to escalate in their voice, and it was starting to make me a little uncomfortable. And I just, in that moment, thought to myself, okay, I gotta practice what I preach. So I stopped the conversation and I said, Dr. X, or are you angry with me? And it was a pause in the conversation. No, I'm not angry with you. I'm angry at the situation. I'm angry that we keep coming back to this. I'm angry that, and that started to escalate again. And we started to raise our voices, and we started to have the conversation wasn't going in the direction we needed it to go. So I stopped us once more. I recognized or I acknowledged that frustration. I said, I can hear it in your voice. I can hear that you're passionate about this. And I want to work together. I want to make sure that we can fix this so that no one else gets hurt. And then I said, but if right now isn't the best time to have that conversation, let's pause. Let's bring it back tomorrow. Like, let's have some time to be able to think about it and then let's come back. Because not everyone in the moment is able to have that emotional intelligence or that crucial conversation right when you're ready. So being able to be mindful of, is this a good time to have that conversation? I think is really important.
Very wise. Very
Yeah.
wise.
Wonderful story. An example of how we can stop, slow down, choose the words that we want to choose where we're not attacking, but maybe we're curious, we're approaching with curiosity about what might be happening here and offering other ways to be able to communicate. I love that example. Are there other resources at Mayo Clinic that can help people with issues around experiences or maybe to your point, Jamie, conversations that maybe didn't go well and they're still struggling with managing that?
Well, I always recommend that you talk with your upline leadership. Find resources through them, have common conversations, let them be able to help you. That's why they're here. A couple other ways is the help program, and that's healing the emotional lives of
Very
peers.
good.
So
Mhm.
it's individuals within our organization that are trained to listen and they're there to empathize and they're there to just be someone who can support and um, even give some of their experiences as well. Like I feel you. I understand how that felt in that moment. And I've had that experience and just being able to empathize with you. The other program is EAP, Employee Assistance Program, which are clinically trained individuals. You can have phone calls, you can have face to face, lots of different ways to be able to interact with them. And it's also available to the loved ones, employee members as well. And what a great way to be able to a resource for us to be able to speak to other people and get some tips and tricks from others that have experienced it. Thanks.
Well, Dr. La Nou, we're coming to the end of our podcast, but I'm just curious, you all have been working on this now for many years. I know this has been part of Mayo Clinic's safety culture work for at least 15 years. We've been talking about how to continuously improve. If you were talking to a colleague at another organization who, really hasn't started up intentional work around this area, what would be the first one or two things you'd tell them to focus on?
Well, I think first I would caution them a bit that sometimes as we're trying to change culture, they might meet some resistance. So I think is can be difficult at first to go into a department or go into an area and try to change culture and help people be more open. So I would caution them to be open and understanding that it might take some time. I would recommend that they meet with multiple different people throughout the department, not just the leadership, but we've had great luck on patient safety just approaching the staff one on one, and not in like an intimidating way. We don't, want to call people into a conference room and grill them. We want to approach them where they're at and ourselves like set an example of how we can be open and inviting.
I'm going to add in that just recognizing and remembering we're human. We all make mistakes. That is part of, unfortunately, medicine as well. So if we can approach situations and normalize some of the second victim, I know we didn't quite talk about that, but that those emotions and feelings that our staff feel after they make a mistake are a really important thing to recognize.
The other thing that I just wanted to make sure that we pointed out is that when we talk about instilling psychological safety in a culture, it's not just one presentation that we give to staff and then we have fixed the problem. This is definitely one of those really important pieces of our culture that we have to constantly be cultivating and reinforcing. So, as leaders, when we're walking the halls, want to constantly be remembering that even just the way we present ourselves can feed into that. It's definitely not a one and done with this
Work
particular
that's
topic.
really, really never done.
Right.
Yeah.
Yeah.
Well, wow, you three, you've given us so many wise things to think about. And I just want to express gratitude to each of you for taking time. My goodness, Dr. La Nou, after a night on call, very sacrificial of you.
Yeah.
Thank
Thank
you. And,
you.
and just for the work that you've all been doing over these many years on behalf of our colleagues and our patients. So, as we wrap up today's conversation, we hope that it's clear that speaking up isn't just a skill, it's a responsibility. Whether you're raising a concern or asking a question or offering a new perspective, how you approach those moments we've learned can really shape the safety and the culture of the entire team. So, creating that space for open, respectful dialogue, it really doesn't seem to happen by accident. Our brains are wired differently when the stakes get very high. So it takes intention, practice, self awareness, and a belief that every voice really matters. As you guys take these things back to your day, we invite you to reflect on what you've heard. Consider maybe just one way that you can help make it easier for someone else to speak up around you. Because I think when we lead with curiosity and humility and courage, and self awareness, we don't just improve safety, we really build the culture that is going to help everyone thrive. We've come to the end of the podcast. We're glad you could join us, and we hope the information provided has been insightful and valuable. Again, Mayo Clinic's Key into Quality podcast aims to highlight some of the first steps in addressing important quality challenges in your organization. Our goal is to improve the quality for patients and the populations that we all serve. If you enjoyed this podcast, we'd be grateful if you left us a review on Apple Podcasts, a rating on Spotify, or feedback wherever it is that you listen. You can also follow us on your favorite podcast platform. Please let others in your organization know about these podcasts so the information can be spread. Until next time, goodbye.